Hello everyone, this is part 9 of our drug of choice series. In this we are going to discuss about the various important and commonly encountered toxicities and poisonings. These are the topics we are going to cover in this video. So let's get started. The first one we have is opioid poisoning or opioid overdose. This is usually detected by the presence of tiny pinpoint pupils, cold or clammy skin, choking, respiratory depression, etc. The first step in these cases is to initiate the BLS protocol and focus on respiratory support, providing oxygen via a mask or in severe cases going for intubation. Once respiratory support is established, naloxone is administered intravenously to reverse the effects of the opioid. Next in line, we have organophosphate poisoning, common amongst farmers due to heavy pesticide use. This picture depicts the classical symptoms present in OP poisoning. The first step is to make sure that the airway, breathing, and circulation are intact, and if not, providing the required support. Washing with soap and water helps clear the residual substance which may be present on the skin. IV atropine is used, followed by pralidoxime, which is a cholinesterase agonist and further helps in reducing the cholinergic effect seen. Next, we have MDMA or cocaine overdose. The first line is to make sure that the airway, breathing, and circulation are normal, and if not so, to work on establishing support. IV fluids are considered to be a good choice. Benzodiazepines are also used. In cases with associated hypertension, sodium nitroprusside is advised, while in cases of associated chest pain, glyceryl trinitrate, or in short GTN, can be used. Finally, in cases with associated extreme hyperthermia, mechanical cooling is undertaken, and if this doesn't work, a drug called dantrolene is administered. Let's now move on to benzodiazepine overdose. The first priority, even here, is to establish airway, breathing, and circulation. And once this is established, a drug called flumazenil is used to reverse the effects of a benzodiazepine toxicity. As doctors, we know that adrenaline can be a life saving drug in certain situations, but there is a possibility of accidentally administering adrenaline. For these cases, an antidote is available and it's called phentolamine. It is an alpha blocker and it is given intramuscularly. Next, we have paracetamol overdose. This is quite common. The first step is to start IV fluids. This is to avoid hypokalemia, as it is a common occurrence. If it has been less than 1 hour since the poisoning, activated charcoal can be tried. However, in certain cases where it has been more than 1 hour since the poisoning but less than 8 to 10 hours, then N-acetylcysteine is given intravenously or methionine is given orally. These substances greatly help in reducing the toxic effects of paracetamol poisoning. The patient must be closely monitored, and a variety of tests like ABG, INR, and paracetamol serum levels are done to monitor the condition. There is something called King's College criteria, which helps in determining the degree of liver destruction and if the patient requires a liver transplant. Next, we have cyanide poisoning, commonly caused due to nitrates or bitter almonds, etc., characterized by the appearance of brick red skin, and it is associated with CNS and respiratory depression. The first step is to offer respiratory support with 100% oxygen, and if this doesn't work, proceed with intubation and ventilation, followed by hydroxycobalamin intravenously with special agents like cobalt editate or nitrites like sodium or amyl nitrite. A similar picture may be seen with carbon monoxide poisoning with CNS and respiratory depression, but here the color of the skin is described as pink skin initially, followed by cherry red skin later on. The first step is to start 100% hyperbaric oxygen and monitor carbon monoxide hemoglobin levels. If it's more than 10%, then intubation with ventilation is considered. In certain cases where seizures may precipitate or there is early history of seizures, diazepam may be given intravenously. Next, we have lead poisoning, characterized by blue gum lines, motor neuropathy, and basophilic stippling. D-penicillamine is used first line as a chelating agent. Other options include DMSA or dimercaprol, etc. Lastly, I would like to discuss three agents which have a reasonable value in toxicology. The first one is activated charcoal. It is most effective when used as early as possible, preferably within an hour. It helps with poisonings like aspirin, quinine, carbamazepine, or theophylline. Next, we have DMSA, also called Succimer, used in lead or arsenic poisoning. Lastly, penicillamine, used in arsenic and copper poisoning. With this, I would like to conclude this video. Hope you guys found it useful. Thanks for watching. Stay tuned for more videos like this.